Welcome to this maybe last session of the day, and it's great to see you here. My name is Arthur van Zanten. I'm an intensivist from Ede, the Netherlands, and professor at Wageningen University. And at my right side for you left is Professor Elisabeth De Waele from the Free University Hospital here in Brussels, Belgium. And at my left side for you at the right side is Professor Gunst from the Catholic University in Leuven. So it will be a fight among two experts of the field from Belgium, here right in Brussels in Belgium. And as you see, they hired a person from the Netherlands to keep them apart. But before we start the discussion, I want to ask you, who of you has an indirect calorie device in the ICU and uses that to in your patients? Right. So I think maybe 30-40% of the group. Now, before we start, do you think we should use indirect calorimetry to guide nutrition therapy in the ICU? Who is in favor of that? And who is against this idea? There's one. So I think Jan has a big job to do, but we will do this again maybe after the session so that we have all the arguments and reasons why we should or not. The floor is first for Elisabeth for the pro position. So she's in favor of the idea of indirect calorimetry. Elisabeth.
Thank you very much. And indeed, it's nice to see all of you. And please remind us that this is a friendly debate. There is no universal answer, although you will see that my answer is closest to the truth. So, first of all, why would you be pro indirect calorimetry to guide feeding? The first question would be, do you actually want to know energy expenditure? Because an indirect calorimeter is just a machine that is designed to measure energy expenditure. So that is the first question. Now, the answer to the first question, do you want to know the energy expenditure? Well, if you want an answer to a scientific question, you have different levels of evidence, and the weakest one is that of the expert opinion. And last Monday, we had an excellent metabolic course guided by Professor Prezer, and there we had a statement from an expert who said, Monday at 12:17 a.m., today we say, if you want to know energy expenditure, we use indirect calorimetry nowadays. And I believe that this is your colleague, Dr. Gunst. Yeah. So, first of all, this is an expert opinion, but we do not rely on expert opinions, as we will probably see later on. So let's go to a higher level of evidence, and there you're all put together at the guidelines. We talked about guidelines, but both the European guidelines of 2019 and the revised version of 2023 states as a first strong consensus and strong recommendation that indirect calorimetry is the first choice if you want to know the energy expenditure of your patient. And then you have second best, third best, and so on. So in the ESPEN guidelines, European guidelines, it is a grade A recommendation to use indirect calorimetry if you want to know the metabolic rate of your patient. So this is a guideline. You can actually see that it's no longer a yes or no story. It is actually in the flow chart. If you have it, yes. If you don't, or there is a contraindication, you have second best and third options, and so on. So it apparently has gained its place in the guidelines that are based on of course, on the available literature and science that is available. So they have gained their place after many years. Now, the first question was indeed, do you want to know it? If you want to know your energy expenditure, and of course you want to know it to make a nutritional prescription, we will talk about that later, you have three options. If you want to know, for example, the temperature of your patient in ICU, you could feel the forehead like mothers and fathers would do with their child when they think they're ill. You could actually take a thermometer and measure it, so you could measure it, and you could guess it. You could say like, oh, it's a little bit red on the cheeks, maybe he has a fever. So you have three options if you want to know a certain value, and the first one that you could do is guess, because of course we are very good clinicians, and we sometimes think that we can know what is the metabolic rate of a patient. Now, I can agree with you partially that this is possible in some patient populations. For example, stable cancer patients, you know that they will have this low-grade inflammation, and we know that their metabolism might be a little bit higher than most of the time. So in more simple cases where you have less determinants of metabolism, you can actually maybe guess the energy expenditure. But please have a look at this paper from the chairman's group, where all the factors that affect energy expenditure in critical illness are aligned. So this means that all of those factors will have both a positive or a negative effect on metabolism. And the actual metabolism will be the result of all those influencing factors. So if you as a clinician want to guess it or feel it, you have to have all those things in mind. And just a little bit in detail, we all know, for example, that when temperature goes down, your metabolism goes down. That is what certain animals do in wintertime. They go down in metabolism to survive the cold, or the other way around. When you cool them down, their metabolism will go down. So we know this, and we can take that into consideration when you're standing next to a patient. Then there is the effect of time. We talk a lot about timing of nutrition, and it's very important to realize that metabolism of our patients changes over time. There is not a one static value, just as your heart rate or your temperature of the patient will change over time. This is some data from the States, from Paul Wischmeyer's group, and we have our data on COVID-19 ventilated patients measured by indirect calorimetry. And you can see that this idea that we might have and that I had before, that first you have hypermetabolism and then it goes down, it's actually not the case anymore. Of course, things, once again, all the influencing factors. Those patients were treated with the old school ICU treatment, ventilation, sedation, everything old school. So maybe that has something to do with the fact that it's rather low and then it went up. So once again, please remember that time has an effect on metabolism, so it's not possible to have one number for the entire period of the patient. This is a slide by Professor Van Zanten where you can actually also see this time lapse. And I think it's really important that we erase this visual memory of the high metabolism and then the recuperation and so on. We erase it from our thoughts because it is not proven in recent publications that this is still the case for our patients. So the acute and late and so on, that's like 40 years ago. So time has an effect on metabolism. Pathology, we got the question, I think yesterday, or I don't remember which day it is, but we got the question, does pathology has an impact? This is a very recent publication by a surgical group that says, here you see the evolution in metabolism over time on one side of head trauma, so neurotrauma patients, and chest trauma patients, and apparently they have a different metabolism. Think about the 20 parameters. They might be different in those populations. So I cannot explain because it's very hard to put all those confounders together, but actually pathology will also have an impact on the energy expenditure of your patients. So we have seen several influencers, let's say, of metabolism. Now, this is an overview that we published. So once again, you have a lot of parameters that will increase the metabolic rate. You have a lot of parameters that will decrease. Some of them do not have an impact. And in our series, C-reactive protein was not correlated. And I was like, still having a headache because I thought that CRP would have a large correlation with metabolic rate. That's what we think. When you're sick, your metabolism goes up, or septic patient, oh, very hypermetabolic. It's not the case. So all those parameters are almost impossible for our human brain to assess at the bedside of one patient and say, because of all of this, I just know that this patient is going to be hyper or hypometabolic. So that's the question of the, let's say, influencers. So guessing in ICU is very difficult. Okay, maybe you could calculate because you want to know the energy expenditure. I'm only going to show you one slide because there are, I think, tens of hundreds of papers comparing measured to calculated energy expenditure. And this is by Professor Ridley here in the room. Conclusion, clinically significant variation was observed between measured expenditure and guideline recommendations at all time points. So the recommendations like 20-25 kcal per kg per day, that is a calculation that you would make to get to the energy expenditure of your patients. And there are more than 200 equations trying to do that, trying to give you the energy expenditure of a certain patient. And most of them are largely inadequate in predicting that for critically ill patients. They perform better in oncology or COPD patients, but in intensive care, they're really bad. So calculating has proven all over again that it's not doing what it's supposed to do. So we had guessing, we had calculating, and then you have measuring it. It's actually taking a measurement tool and measure something. Please don't forget, we are in intensive care. We measure a lot of stuff every day in invasive and non-invasive way. If you want to measure, what will you do? You can use the latest generation indirect calorimetry. I do not have any intellectual property or whatsoever in this device. I just assisted with the development and implementation validation. So if you have this machine, what it will do, it will measure oxygen consumption, it will measure carbon dioxide production, and then if you know that the nitrogen is inert and doesn't change with the gas exchange, by this oxygen consumption, this carbon dioxide production, you can actually once again calculate in an indirect way the metabolism of your patient, because the direct way, putting your patient in a room with temperature changes and so on, that's impossible. So this is the indirect way of measuring your energy expenditure of the patient. That would actually look like this. It was during COVID, you would connect it to the ventilator, and like 8 or 10 minutes later, you would have a number appearing on the screen. And you see the dietitian waiting for this number to be able to give the right amount of nutrition to the patient, but that will be later on. Those are two examples of the results. And of course, some of the results will be 1,800 and they will be 99% of the predicted value. But here you have two results, 2,383, which was 67% of the predicted value, and the predicted was done by the ESPEN guidelines, 25 kcal. So the real metabolic rate of this patient was more than 30% different than the calculated one. So if you would use the calculated, you would overfeed by 30%. And this is the clinically relevant that Professor Ridley mentioned also in her paper. On the other hand, 3,067. Very high metabolic rate in a normal BMI patient with a COVID-19. Very stable measurement. Those are the outliners of metabolism. When you measure, you are not afraid of this. You just know that this is actually the metabolic rate of the patient. But you see the large deviations from the calculations. Now, one last illustration of where measurements really do not confirm the metabolic rate. Here you see another paper where there is a difference of 1,400 kcal a day. If you would actually base your prescription for enteral or parenteral nutrition on your measurement, you would make an error of 1,400 kcal a day. Try to eat yourself 1,400 kcal a day more than you're used, or less. After a few days, you won't feel good. So this is the same for our patients. Contraindications, of course, it used to be difficult to perform it because of technology was challenging, and we had a lot of contraindications. Well, we have overcome CRT. You can perfectly perform indirect calorimetry during CRT. It's even advocated to do so in the ESPEN guidelines on acute kidney disease because it changes a little bit your metabolism. So yes, you can do it. ECMO is still quite challenging. We have done 7 patients, but it took us 4 or 5 hours per patient, 5 people. So it's not ready for the bench, but it's feasible, let's say. And then yesterday I saw this paper in children where they're actually doing measurements on non-invasively ventilated children. So this is another hurdle to take. So we are more and more overcoming the contraindications, which makes it more feasible in clinical practice, but there will still always be patients where it's not feasible to perform this technology. Now, second question, I will go quick. If you know to measure it, do you want to use it to guide your feeding? Because this is the second question. Well, our friend Dr. Pucciuari said here, well, personally, I think he was not such a big fan, not all into the hype, but he said, the use of indirect calorimetry may help to better match nutrition requirements and avoid overfeeding. And this is something that we all like. We don't want to overfeed. So probably here in this paper, they said it can play a role and it can be a benefit to avoid overfeeding. There is a meta-analysis. I won't go into details, just telling that, yes, there is a lower 28-day mortality when you actually guide your nutrition on indirect calorimetry. And this is another one, Duan in critical care. I sent him an email. Thank you for your meta-analysis. He never replied. I don't know why. So it's really important that people outside the nutrition world also do this kind of exercise to see what's actually right, yes or no, because we are just too much in the tunnel. But this was really a milestone for indirect calorimetry in critically ill patients. And maybe, Dr. Gunst, the fear of missing out can be also something to worry about, because I have this paper, the Van Zanten, this is what they do every day, indirect calorimetry. I have this picture with Dr. Reintenbläser, and it's in German, but I could still see indirect calorimetry. So it's in their daily practice. So more and more people are actually have implemented it, are doing it. We have nurses doing it, just performing the measurement and giving the results, and very good implementation. So it's just growing and growing and growing, and more people are doing that. Of course, not only the ECALIC research group, also in the States, and I didn't find a picture of Frankenfield and so, but so many people have experience and positive experience with using metabolic cards or indirect calorimetry. So in the end, I think that you will no longer stay aside and you actually agreed with the use of indirect calorimetry in this paper in critical care. So there I go with my pro, and thank you for your attention. You want to know, you can measure, and you can use. Thank you very much.
Thank you very much, Elisabeth. And now the floor is for Jan. It will be a challenge, but we will listen carefully.
Sure, thank you very much. It will be a challenge indeed. So just to briefly comment on the paper, as you know, there was a big discussion on the paper, and there's this sentence at the end stating that not every expert is agreeing with every sentence in the paper. So just to...
That's a guideline story.
So I have no conflict of interest with regard to this presentation. Important to mention, I have received research grants, but they were all academic research grants, no commercial funding. So why indirect calorimetry? Well, of course, we want prolonged underfeeding has been associated with poor outcome of patients, and theoretically, prolonged underfeeding could contribute to sarcopenia. And in this regard, feeding has been presumed to be beneficial. And so, despite observational studies associating underfeeding with poor outcome of patients, randomized controlled trials actually have shown no benefit of early full feeding. And in fact, we have large RCT data that showed no benefit of early full feeding, and several RCTs actually showed harm by early full feeding. So these RCTs have, of course, been criticized, as happens always with RCTs, and one of the critiques on the RCTs that showed harm by early full feeding has been that the feeding target was not individualized, and that the feeding target was not based on indirect calorimetry. So this has been a critique on these trials, and indeed, as Elisabeth has shown, predictive equations indeed do not accurately predict energy expenditure. So, and this would be the main reason to implement indirect calorimetry. So, but would use of indirect calorimetry actually have turned harm by the early full feeding into a benefit? I don't think so, because there are many reasons why indirect calorimetry in the early phase is not useful. And I will go with you through these reasons. A first reason is that the underlying hypothesis is actually wrong. The energy expenditure, of course, if you want to measure it, you should use indirect calorimetry, but it's an energy expenditure does not mean that this is the energy need at all times in critically ill patients, because acute critical illness is characterized by anabolic resistance, and the duration of this anabolic resistance is probably variable between patients, and the actual duration is unknown. So even with a progressive regimen, you do not know if the patient has a response anabolically to feeding. And indirect calorimetry does not quantify the endogenous energy production that can be suppressed by feeding or that cannot be suppressed by feeding. And several studies have shown that indeed there's anabolic resistance in acute critical illness. This is a secondary analysis from the EPANIC trial, which showed harm by early parental nutrition. And in patients who had a muscle biopsy taken in the study, our group has shown that the feeding actually did not do what it's meant to do. So there was a loss of myofiber size in both randomization groups, and giving early parental nutrition did not prevent the muscle loss. So there's anabolic resistance in critical illness, and many other studies have confirmed that. A second reason why not to use indirect calorimetry is when we look at why early full feeding was shown to be harmful, there are different mechanisms why early full feeding was not beneficial. And I don't have time to go into detail because there's several potential mechanisms involved, but one of the main mechanisms seems to be a suppression of fasting responses. And in acute critical illness and to recover from critical illness-induced organ failure, it seems to important to activate to have active recovery processes. And autophagy, for example, is one of the important repair processes in critical illness. And this repair process is powerfully suppressed by giving nutrition to critically ill patients. So, and in secondary analysis of the EPANIC RCT, our group showed that the harmful effects of early parental nutrition were in part mediated by suppression of fasting responses. Also, ketogenesis seems to be important, and feeding also suppresses ketogenesis. So fasting responses appear to have some beneficial effect in critical illness to recover from critical illness-induced organ failure. And when you feed critically ill patients, regardless of what the target is, indirect calorimetry will not prevent these mechanisms of harm. So this is actually what I said with autophagy. So in critical illness, the cells are overwhelmed with cellular stressors, which leads to cellular damage and organ failure. And autophagy is, as said, a repair process that is powerfully suppressed by nutrients. So if you feed based on indirect calorimetry, you will not prevent this suppression of autophagy. A third reason why not to routinely use indirect calorimetry is that the energy expenditure is actually variable over time. And Elisabeth showed the factors that determine the energy expenditure. And the energy expenditure is not constant during the day and may also vary from day to day. So how to translate a value that you measure at one single time point to a 24/7 nutrition target? It would be the same as if you would be measuring blood glucose only once every 2 days or only once a week and then administer a fixed dose of insulin. A fourth reason is that indirect calorimetry, as the name says, it's an indirect measurement. So the formula has intrinsic assumptions about how substrate use and so these assumptions may not necessarily be valid in critically ill patients. You basically measure the oxygen consumption and CO2 production, but there are actually 3 substrates that can be oxidized, which have a different RQ. So there are inherent assumptions, and there are also measurement errors, which makes the measurement less accurate than it seems to be. Another reason is that randomized controlled trials on indirect calorimetry-based feeding versus formula-based feeding have shown no difference in outcome. The largest randomized controlled trial, which was the Tikakos International trial, to which Elisabeth contributed, actually showed no difference in outcome. And Elisabeth has referred to 2 meta-analyses that show the potential benefit. However, the problem with this meta-analysis is that they actually have a very high risk of bias. And why? One of these meta-analyses, the second one used erroneous mortality data from Tikakos International. So for the Tikakos International RCT, initially there were some errors in the reported mortality data, and these were only corrected after 2.5 years. And so the meta-analysis used the erroneous mortality data, unfortunately. A second reason is that in the latest meta-analysis, there were RCTs included with a very different design. So there was heterogeneity in design between the included RCTs, and not all RCTs actually compared indirect calorimetry-based feeding versus formula-based feeding. And then third potential reason of bias is that the fragility index actually is very high. So it means that the perceived benefit on mortality is just dependent on one patient. So if one patient in a meta-analysis would have had a different outcome, the significance would be lost. Also, it's unclear how the mortality benefit would be explained, and in the meta-analysis of the group of Pierre Singer, as Elisabeth showed, there appeared to be a reduction in 28-day mortality, but on the 90-day mortality, there was no benefit anymore. So a very short-term benefit, and with unblinded trials, there may be a risk. This may be confounding. And then another last reason is that routine use of indirect calorimetry is not feasible, neither cost-effective. The largest randomized controlled trial on indirect calorimetry-based feeding, the TICACOS International RCT, was actually stopped because of slow recruitment and a high number of protocol violations. And only 339 patients actually followed the protocol, and this occurred in 7 centers over 6 years. It means that in this RCT, approximately 8 patients have been included per center per year in whom the protocol was followed. So in conclusion, use of indirect calorimetry gives a false sense of accuracy. It does not quantify the endogenous energy production that is suppressible or not suppressible by feeding. It does not prevent the harmful effects by blocking the fasting response, and the energy expenditure is variable over time, and this is not taken into account. There are inherent assumptions in the formula, and frequent repetition of indirect calorimetry is not feasible. So indirect calorimetry will not translate harm by early full feeding into a benefit of early full feeding. So, of course, the question is, with that and why indirect calorimetry has been proposed is because we want to individualize feeding, and how, at what time point and when and how much should we feed our critically ill patients. I think we need a ready-to-feed indicator for that, because in acute critical illness it has been shown that patients have anabolic resistance and that have an adverse response to feeding. And at some time point this will switch towards feeding responsiveness, and in this phase macronutrients are properly used or incorporated into muscle proteins and so on. But at this time, we lack clear markers to indicate or to predict at what time point this occurs. And when we would to allow truly individualized nutrition, we would actually need such biomarker or a combination of biomarkers. And at current, this is unfortunately not available. Thank you very much.
Well, thank you very much, Jan. Maybe it's good to sit at the table. And of course, I want to give Elisabeth time for a response, but I also would like to invite you to ask questions to the panelists and to address all your needs. You want to start first shortly, and then we have a question from
Perfect. I'll start from the last one. Routine use and also the TICACOS trial, we used the latest, an older generation devices, which were much more difficult to use. And with the latest generation device, I can tell you that it's perfectly feasible to use them in clinical practice. We in our hospital, we now have 5 devices with thousands of measurements every year. So we perfectly implemented in practice with the latest generation. The meta-analysis, okay, we heard today that there are also problems with meta-analysis. I think we truly agree that indirect calorimetry measurement, the result is not what your patient needs, but it is a measurement, and with this number, you work on it. So I think we agree. And I'm also very happy to see that you don't like this moment or you do one test and then you take the number. So from my impression, you want indirect calorimetry in a 24/7 basis.
It's available.
In a continuous measurement.
You want to respond? Oh, please. Yeah.
I want to respond. Just, I heard this morning from your colleague, Joop Jonk here, that in your center, indirect calorimetry would be used twice a week. So it's still not continuous use of indirect calorimetry. But, the continuous use of indirect calorimetry or continuous measurement of energy expenditure, would be more informative, but it will still not solve the other concerns that I have with indirect calorimetry, being that you do not quantify how many endogenous substrate production is actually suppressible by feeding, and also some the inaccuracies and the assumptions of the measurement and all the other concerns that I have are still valid. So it would only tackle one potential aspect.
Okay, let's have the Julia. You want to ask a question?
Both speakers. Do they believe that early full feeding is detrimental, whether you've got indirect calorimetry or not? And when would you start using indirect calorimetry to define the feeding dose that you might give, whether it's daily, twice a week, or whatever?
Maybe Elisabeth.
Well, let me say that this early or late discussion is not the right terminology, especially when you work in days, because patients differ, and this is why we like to measure the patient so that you know where they are. I think we both agree that you don't have to go full on day 1 or 2, or let's say as long as the patient doesn't have a controllable shock or a lactate lower than 2, because that is a more physiological cutoff. So on the early days, no. On day 3, we use it because on day 3 or 4, you want to be on target. And if you want to know your target, or you use 2025 and you take 70% of that one, which is a calculation on a calculation, or you do a measurement and you take this number, because until now, this is what is advocated in the guidelines. So day 3 or 4, and then you repeat it whenever is possible from a practical point. So that would be my answer.
Yes, actually, we do not know how long the acute phase lasts in acute critical illness, and there's probably much variation between patients. And actually, what we do in our center is that in the first week of critical illness, we're rather restrictive with feeding. So we try some enteral nutrition if it's possible, and we gradually increase towards target, but we do not start supplemental parental nutrition or total parental nutrition before day 8 in ICU. And actually, last year, the Nutriria 3 study actually confirmed harm by early full feeding in the first week in ICU. So we would not use indirect calorimetry in the first week in ICU because, well, you showed the stepwise increase in nutrition over the first week, but it's actually an assumption that the endogenous glucose production would gradually fade away, and that it would be 25, 50. Well, I don't know the numbers by heart, but you just assume that simultaneously or in parallel the endogenous glucose production fades away. So. Yeah,
it would be nice to know the endogenous energy production, to measure that one.
Maybe
nice
I can add something to the discussion, because I think we're mixing up some issues. So when we have like an arterial line to measure blood pressure, does it mean that we exactly know what is the individual target for blood pressure? It can be like a neurotrauma patient, can be post-resuscitation, can be septic shock without hypertension, with hypertension, on ACE or ARB, and they probably all will have different targets. The question to the panel is, should we stop then measuring blood pressure because it's in vain to have this reading? So what is your opinion about that?
Well, as I said, in the acute phase of critical illness, patients have anabolic resistance, so they will not respond properly to nutrients. And if you give if you give a high dose of nutrition in the first week, it will be detrimental through suppression of fasting pathways. If you just give a fraction of the energy expenditure, it will equally block these repair processes. And as soon as you're giving just a fraction of energy expenditure, it's as inaccurate as just giving a fraction of the estimated energy expenditure. So it's adding an inaccuracy on top of a measurement that you assume to be accurate, but which has its inherent assumptions. Maybe having said that, because the previous question was, would you never use indirect calorimetry? We would consider it, but not in the first week in critical illness. We would only do it in stable patients in the late phase of critical illness, when you have a patient who is difficult to wean from the ventilator and who doesn't have an acute event. Then we would.
Wow, I see some light at the end of the tunnel. We agree now about later.
In 10 years, you will do the probe. Yeah.
I was about to say that the same concept than you, Art, is that if you have a pulse oximeter, we will not set the ventilator to get 100%. We will adapt according to this situation. If a patient has IRDS, we will probably target 92 and not 100. So it's important to get a monitoring device, and it will be very difficult to show that the monitoring device improves outcome, but that it helps to guide the treatment is probably something which is much more realistic. And in this view, I think that we should not overinterpret the data. Problem is that, of course, these measurements are intermittent and not continuous, and that we have to move the indirect calorimeter from one patient to another in most instances. Some ventilators have some built-in calorimeters, but these are less accurate and probably more expensive as well. So we cannot keep the IC in a patient for long. But anyway, the monitoring device serves as a monitoring and not as a therapeutic goal.
Okay, more questions or comments from the audience? Yes, please.
Just one question for the two speakers. Thanks a lot. There are a couple of modern ventilators that have integrated a metabolic tool. The VCO2 is included. What do you think about that?
Well,
to guide your therapy all day long, because it just takes a look on the ventilator to see what the VCO2 does.
Thank you very much. First of all, we recently published a very interesting paper in Sensors together with some engineers. I understand half of it, but so we have a paper in Sensor explaining all of that. And it's very interesting because indeed, oxygen consumption is 4 times as important as carbon dioxide. It's 1.1 and 3.9 times the oxygen consumption and 1.1 carbon dioxide. So the oxygen is the most important one in the rare equation. So of course, if you have both, this is more accurate when you compare it to a mass spectrometry, for example. If you have the carbon dioxide, it's second best, and you have done a lot of work around that too. It's second best, but you will use a predefined respiratory quotient of 0.8, which is an assumption in intensive care. And in intensive care, that's a little bit dangerous. Outside, it could be more valid. So this is why you have handheld machines for other situations. So the good thing is that it's built in, but the bad thing is that you can only use it in one patient at a time, being the patient attached to the ventilator, where with the new generation devices, you can take it from one patient to another outside ICU, which from a healthcare economic perspective is more interesting. So to answer to your question, maybe you want to also contribute, but yes, it is valuable and it's better than the equations or the calculations. So it's second best.
But then I think it needs to be validated. In randomized controlled trials as well. That the feeding target is better when you do it that way. And I think there's a risk of relying too much on the value, because we do not know actually, as I said, how long the duration of anabolic resistance occurs and how long the duration of untoward effects of feeding occurs. And if you start feeding too much, and if the feeding is not properly used, overfeeding will actually increase the energy expenditure. So there's a risk that you get in a vicious circle of always increasing the feeding intake, because the energy expenditure keeps on rising. So it's something to take into account.
Well, I think time is moving fast. So I have to conclude this excellent debate by two experts. What we've heard, I think that there is a device that can give you some readings of the energy expenditure of the patient. That will not say that at every time moment we have to follow this energy expenditure as the same prescription for nutritional intake. There are several reasons not to do that. We heard about the early phase, the endogenous energy production, maybe suppressing starvation effects. It is also in patients with refeeding syndrome that we know from RCTs that we have to restrict the calories. But on the other hand, we have to learn, maybe in combination with more metabolic markers or indicators of metabolism, that can help us to guide the therapy over time. And we use it every 3 days, and we see huge difference in the energy expenditure. I think there is more need for studies also showing that when you follow this guidance that you get a better outcome. There are some, they are meta-analyzed, there is some debate on the quality of the meta-analysis, but I think it's a starting point, and I believe that in the next few years we will know whether it should be the gold standard for energy expenditure, or I think it is the gold standard for energy expenditure, but whether it's the gold standard for prescription of energy in the ICU still remains to be addressed in the future. I think this kind of debates helps us to sharpen our minds and to do the right studies in the future. And, I hope you enjoyed the debate, and I wish you a very good night, the last night of this symposium, and we hope to see you tomorrow.